So our next speaker is Pamela Thomas. Pamela is a PhD researcher at University College London, Division of Psychiatry, focusing on the design and development of digital interventions for eating disorders. Pamela's talk today will explore digital treatments for mild to moderate eating disorders, focusing on outcomes influenced by theoretical frameworks, delivery modes, and behavioral change techniques. So over to you, Pamela. All the best.
Thanks so much, Shruti, for the introduction. Good morning, good afternoon, everybody, wherever you are. Firstly, I'd like to thank John and the organisers of this event for inviting me to speak at this inaugural event of digital psychiatry. I think it's a field which shows kind of great promise for transforming mental health care, including in eating disorders, as we'll talk about today. I'm going to be discussing a systematic review and meta-analysis which examines the role of digital interventions in the treatment of people with mild to moderate eating disorders, which is an area where access to care often falls short of demand. This research not only evaluates the current evidence, but it also identifies the gaps and opportunities for innovation in digital intervention. Our aim was to provide actionable insights into what works, why it works, and where further research is required. So let's get started. As many of you know, eating disorders remain a significant and complex challenge in both clinical practice and also public health. Research consistently highlights its association with decreased quality of life and substantial disease burden. Despite this, the vast majority of people with eating disorders still remain unsupported, with as few as 1 in 4 actually seeking help. So digital interventions present an opportunity to address these challenges, as they can overcome many of the key barriers to help seeking, such as stigma, shame, and limited availability of services. Previous systematic reviews have demonstrated the potential for digital eating disorder interventions. However, the mechanisms via which these interventions are effective is less well understood. Yardley have emphasised the importance of using evidence-based methods and behaviour change theory when designing interventions to ensure that these interventions are not only theoretically sound, but they're capable of facilitating meaningful and sustained behaviour change. Therefore, the aim of this study, or this review, was to identify the behaviour change techniques within digital interventions for the treatment of eating disorders, to understand which of these components may contribute to the improvements in terms of eating disorder outcomes. I think for those of you less familiar with the concept of behaviour change techniques, these are the observable, replicable, and irreducible intervention components which are designed to modify a behaviour. So by identifying the specific behaviour change techniques which are most effective, and ensuring they're rooted in theory, we can design interventions which are both evidence-based and strategically targeted to address the core mechanisms maintaining eating disorders. We also looked at the theoretical basis of intervention design. This means looking at frameworks or models, such as cognitive behavioural theory or transdiagnostic approaches that underpin these interventions. Understanding theoretical foundations is essential because it tells us why specific techniques are included and how they're expected to drive behaviour change. So that gives a little bit of background into this study and why it's sort of important and what we hope it will tell us. I'm just going to go into some detail around sort of the design. So in terms of the inclusion and exclusion criteria, there are a few things that I'd like to sort of highlight. Based on a desire to understand how digital interventions can be effective in terms of supporting sort of treatments, we focused on self-guided interventions and those with minimal therapist support. This allowed us to isolate the BCTs embedded with interventions, whilst also recognising that some degree of therapist support might be required. Secondly, we focused on interventions aimed at early intervention and also treatment. These provide a critical window to evaluate the impact of digital tools before symptoms become severe or entrenched. Finally, we limited the scope to the adult population to ensure consistency in analysis, and also recognising the fact that interventions targeting adults may be distinct from those targeting adolescents in terms of kind of their content, their delivery, and their goals. So focusing on adults, we can more clearly evaluate the effectiveness of these behaviour change techniques within this specific demographic. We completed a comprehensive search across a number of key databases to ensure broad coverage of medical, psychological literature and multidisciplinary research. The search strategy was structured around two key concepts for eating disorders and digital interventions. And then the interventions were evaluated using three established sort of frameworks. We applied the behaviour change taxonomy, which allowed us to systematically identify and code the behaviour change techniques within the interventions. The mode of delivery ontology, which allowed us to categorise the delivery methods of the interventions. And finally, the theory coding scheme, which enabled us to examine the theoretical basis underpinning the design of the interventions. This led to, we identified 7 studies as a result of this. 12 of those were waitlist or treatment as usual kind of comparators, whilst 5 had an active control. 12 included internet-based interventions. 2 were combined, sort of a hybrid of internet and app, and 3 were app only, demonstrating some of the diversity within which how these interventions are being developed. And they included a range of different kind of eating disorders, including binge eating, bulimia, and then 8 across any eating disorder, demonstrating kind of a broader transdiagnostic perspective. We did also evaluate the quality of the studies, which was generally good, although there were some concerns in some areas, such as missing outcome data at follow-up. So in terms of the results, this slide highlights the behaviour change techniques were identified in over 75% of effective interventions at post-intervention and follow-up. The first 2, self-monitoring of behaviour and outcomes of behaviour, emphasise the importance of increasing awareness, helping individuals track their eating patterns, identify triggers, and reflect on the consequences of their actions. Next, feedback on behaviour ensures that individuals receive constructive input on their progress, reinforcing positive change while also identifying areas of future growth. Another critical technique was information about antecedents, which focuses on helping individuals understand the triggers and situations which led to the disordered eating behaviours. This knowledge forms the basis of effective behaviour change. Problem solving and action planning are practical techniques. They provide tools to manage barriers and create step-by-step plans for achieving specific recovery goals, such as establishing regular meal patterns or managing emotional triggers. Finally, social support highlights the importance of connection. Whether it's tangible help, such as meal preparation, or emotional support from peers, these techniques ensure that individuals feel supported and less isolated. These were particularly important for sustained effects of follow-up. These behaviour change techniques have been found effective across interventions at both post-intervention and follow-up stages, underscoring their role not only in initiating, but also in sustaining recovery. When applying the theory coding scheme, we identified that nearly all studies reported some level of theoretical basis, suggesting that developers are grounding their work in established psychological theories, which was at first promising. However, while theory was present at a high level, when we looked in further detail, we found that the integration into the design and delivery of techniques was sometimes superficial and often incomplete. For example, intervention techniques were often not explicitly linked to theory-relevant constructs or predictors. I'll give you an example. An intervention might actually mention, for example, cognitive behavioural therapy, but there was often no clear explanation of how specific techniques, such as self-monitoring, were tied back to specific constructs like cognitive distortions or emotional regulation. Additionally, theory constructs or predictors were rarely used to tailor interventions to recipients. Tailoring is really important as it allows interventions to adapt their content based on individual differences in triggers, behaviours, and motivations. We also analysed modes of delivery used in interventions based on the hypothesis that a greater variety of multimedia content might improve intervention effectiveness by engaging users more and also catering to diverse preferences. On average, we found that interventions included around 5 modes of delivery out of a possible 12 modes. And typically, the main modes were quite traditional in terms of, text, web-based messaging and email and so on. We found limited use of multimedia formats such as video and audio, and recommendations going forward would be to increase the use of kind of multimedia formats to provide a kind of richer, more dynamic and interactive user experience. I'll now talk you through some of the meta-analytic findings sort of within this research. I'll talk you sort of through it for those of you less familiar with it, just to kind of guide you around the sort of forest plot. Essentially, this is a visual representation of the effectiveness of the interventions versus controls at sort of post-intervention. Each horizontal line here represents the results from each of the individual sort of studies. And the square on each of those lines is the mean difference in terms of the eating disorder outcomes at post-intervention. The diamond at the bottom is the pooled mean difference across all of these studies. So we'll see in this example of post-intervention, it's minus 0.57. This means that on average, the results on the EDEQ, a key measure of eating disorder pathology, was minus 5.57 lower for the intervention versus the control. If we look at the p-value, the test for the overall effect of this, it's highly significant. Demonstrating that these interventions were significantly effective at follow-up. I would just like to highlight that, you know, for some of you may think that a difference in terms of 0.57 may not be that clinically significant. Just to highlight that this is the difference at post-intervention between the intervention group and the control group. In some areas, there was actually also an improvement in results for the control group. So actually, the overall result may have been more significant, if that sort of makes sense. A couple of other things I'd just like to highlight is if we look at the kind of numbers included within this study, it's a robust analysis. We have nearly 2,000 participants. And I'd also just like to highlight the heterogeneity statistic, which is the I-squared value of 77%. What this means is that 70% of the variability across the studies was due to real differences between the studies. This means that we need to explore how factors such as behaviour change techniques or theoretical basis, or indeed other factors, could be contributing to these differences in terms of these outcome effects at follow-up. This next forest plot is very sort of similar. We again have the results for each of these individual studies. Fewer studies had follow-up data, but again, we find a statistically significant effect at follow-up, which is highlighted by the diamond, and you'll see it's minus 0.333 for the follow-up studies. If you recall, this is a little bit lower than the results at follow-up, demonstrating that some of the effect is sustained at follow-up, but there obviously it's a smaller effect, which is kind of less significant. I'd also touch on the I-squared statistic here, which is actually 0, so demonstrating the results were very consistent across the studies here. The final meta-analysis, which I'd like to share with you, is relating to the theory kind of coding scheme. And I think just as a bit of a recap, those studies which scored higher in terms of theory coding scheme were those in which theory was used more closely to inform the intervention design. This one's a little bit more complicated insofar as there are two different groups. At the top, you'll see we have those studies or those interventions which scored higher in terms of the theory coding scheme. Here we actually see that the results at post-intervention for the intervention were minus 0.86 for those interventions which scored higher on the theory coding scheme. And then for the studies which scored lower, the average reduction at post-intervention was minus 0.36. This was, if we look at the p-value, this was statistically significant, a statistically significant result, demonstrating that those interventions more highly informed by theory were more effective at post-intervention compared to those which were lower, which were less informed by theory. So just to summarise, we found that digital interventions had significant improvements in eating disorder outcomes at post-intervention, and there was some evidence that intervention's effect was sustained at follow-up. 6 behaviour change techniques was consistently associated with effective interventions, but there was no evidence that behaviour change techniques alone moderated effect size. Interventions grounded in theory may be more likely to be effective, and so it's recommended that theory is used to explicitly inform the design of interventions going forwards. There was limited use of multimedia formats such as audio and video, and also there was limited data regarding the effectiveness of apps to date. So in terms of the implications going forwards, digital interventions may provide a potential solutions, particularly I think for those who have limited access to treatment. It's recommended that those which are more closely grounded in theoretical frameworks, or which include this core set of behaviour change techniques which we now know to be effective, are those which are prioritised. And I think obviously further research is required to better understand which combinations of BCT are most effective, and indeed whether this varies by individual differences in terms of people with different eating disorders and so on. And finally, apps may be helpful as adjuncts to treatment, but we think that more robust evidence is required to design and develop apps going forwards. I'd just like to inform you that this study is part of a broader programme of work where we were actually co-designing and co-developing with therapists and people with lived experience an eating disorder app, which is informed by theory and includes those behaviour change techniques. Yeah, it's progressing really well. We're currently at the stages of initial prototype development and evaluation. Yes, and I'm, be keen to kind of hear questions and to touch base with anyone involved in this kind of field of research. Yeah, I really think we're beginning to understand a lot more kind of what works, but I think, a lot more kind of research is required really to provide kind of more personalized and user-centered interventions to help address the kind of treatment gap and help people with eating disorders going forwards. Thank you very much for listening. I look forward to your questions.
Thank you so much, Pamela. That was such a wonderful presentation. Before I ask my question, I think there are a few in the chat. So I'm just going to read those out. So the first question is by Kithanjali, who's asking, my question is around the reported low-key engagement of young people towards digital-based interventions. With current theories and scientific models evidently being less effective towards retention and engagement of young people globally, could you please share your thoughts towards effectiveness of behavior-based theories in key areas of engagement and retention?
Yes, I think, yeah, I mean, I don't quite know if this relates specifically, I think, to eating disorders, I think, but yeah, I mean, within my work, I focus very much, I think, on behavior change techniques related to effectiveness. But I think similarly, I think we do need to apply these behavior change theories and models to really better understand what drives engagement. Within my work, I've actually been doing kind of focus groups with people with lived experience, really to understand better from them what are these key influences on their behaviours. So I'm not sure what work has been done in that field sort of specifically, but I think we really need to kind of get to grips with what are those key influences on those behaviours, and then have interventions or whatever which target that to help support young people to engage better with interventions.
Absolutely. Can I also please request the audience to post questions in the Q&A and not in the chat, because we're not able to sort of see them in the chat. I do see an interesting question though. So it says, should we move away from focusing on investigating effects of single BCTs, maybe looking on which BCTs make theoretical sense to combine and which clusters of BCTs matter?
Yes, yes, I think definitely, absolutely. I think, here the approach, yeah, I think the approach within this study, we did look at whether we could identify individual BCTs, but I think in reality, absolutely, I think, BCTs do not work in isolation. I think as we saw from the findings, and I think you can understand how self-monitoring feedback, information about antecedents, it could well be the combination of those BCTs that work synergistically, I think, together. So yeah, I think if you read within the study, referring you to the paper, I think we do discuss that to an extent, and I think we discuss, multi-phase optimization strategy as an approach in which you can actually evaluate and look how to optimize intervention designs using different clusters of components. So I think, yeah, I think definitely that would be a recommended way forwards. Yeah.
Great. I think we may have time for one more. And I'm also curious about this. Lynn is asking, curious about access for individuals to engage self-help or guided self-help without a therapist or without any professional direction. Is there an easy way to find hub or pathway for appropriate connection? Honestly, I think I would just like to know about access for individuals to engage without therapist or professional direction. Like, have you thought about maybe a hybrid model, or do you think that maybe involving a therapist would increase adherence and help with dropout rates? Um,
Yes, I mean, I think it's really interesting because I think some studies they're having some studies I mentioned, like RDIM, I think specifically looked at different kind of levels of therapist involvement alongside the intervention, and sometimes we find that the findings are actually counterintuitive. I think that they didn't find a difference in terms of effectiveness with different levels of therapist support. But what they often found was that level of satisfaction and maybe adherence was a little bit better with the therapist. And I think we need to bear in mind the importance of that therapeutic, I think, relationship, which is very difficult, I think, to replicate within a digital intervention. But I think also I would just touch on, I think for some individuals who aren't ready yet to engage with sort of services or aren't able to access help, I do actually think that there's an opportunity for interventions to be made available for people to even just get a better understanding of their condition, even just to prepare them, even if they're on waiting lists for treatment or so on, in terms of a psychoeducational perspective, also just to prevent their symptoms from worsening, and getting access to support, and sort of help. But I think there is a challenge at the moment in terms of how well those services are provided. Obviously, a lot of the apps currently provided with the App Store are not evidence-based and very not very good quality at all. So I think that's sort of a challenge in itself, and I think it's something which my team, and I'm sure others out there, are kind of aiming to address with their work.
Yeah, no, that's amazing. Thank you so much, Pamela. That was a wonderful presentation. And for other questions, please feel free to connect with Pamela offline. Thank you so much, Pamela.